Hello and welcome. I'm Elisa Hernandez, a librarian at Stanford Health Library. Thank you for joining us for our talk, Clearing the Air, Managing Respiratory Viral Infections. It's my pleasure to introduce our speaker, Dr. Randall Stafford. Dr. Stafford is a professor of medicine at the Stanford School of Medicine and the director of the program on prevention outcomes and practices. Dr. Stafford is a primary care physician in the Stanford Internal Medicine Clinic, where he focuses on chronic disease prevention and treatment. He also serves on expert committees advising a diverse range of organizations, including the California Medicaid Program, the National Committee on Quality Assurance, the American Heart Association, and the American Journal of Preventive Medicine. Throughout the talk, please enter any questions into the Q&A box at the bottom of your screen, and at the end of the talk, Dr. Stafford will answer as many of those as possible. Over to you, Dr. Stafford.
It's so great to be here, and thank you for joining us on this evening. And since it is spring, I decided to put a little bit of a springtime feel to this talk, even though it's about viral respiratory infections, which are much more appropriate for the winter. So at this point in my clinical practice, I'm kind of transitioning from viral infections to seasonal allergies. And of course, the seasonal allergies are quite prominent in the Bay Area. And a lot of people have problems with their runny nose and their cough and sneezing. But let's get into this topic. So I'm going to be talking with you today about the topic of viral respiratory infections. And to outline what I'm going to cover, I'm going to talk a little bit about this framework that we call a public health framework, which talks about the host, which is us, the environment, which is what's out there and around us, and the agent. In this case, we're talking about viral agents that cause respiratory disease. And I'll get back to this in a moment. I want to talk about what those viruses are, those causative agents, also about transmission and what we know about the transmission of viruses that cause respiratory infections. I also want to talk about susceptibility to viral respiratory infections. This is the topic that I think, in my mind, has been neglected more than it should. I'll go into detail about what we can expect from symptoms, talk about the prevention of infection, treatment strategies, and the topic of pandemic preparedness. So I wanted to introduce this idea of a public health framework because I think it's very pertinent talking about viral infections. We have various characteristics of the virus, the agent, in terms of how long it survives outside of cells, how long it's contagious, how easy is it to infect people, and what sort of virulence does it have in terms of causing disease symptoms. At the same time, the host is very important in terms of each host being susceptible more or less to a viral infection. Also, their behavior and the contagiousness that they exhibit in that behavior. And then the environment is really important. And for viral infections, particularly how congested or dense is the population of individuals occupying the same volume of air. I do want to point out that this kind of framework works really well for a lot of other conditions. And so here we have depiction of smoking as the agent, with the host again being us, and environment being not just kind of where we can smoke, but also things like policy around smoking. And then here we have traffic-related mortality and morbidity. And of course, the automobile is the main agent in this case. We, again, are the host. We may make ourselves more susceptible to accidents through alcohol use. And of course, we drive on roads and deal with the traffic conditions on those roads. So I just want to put forward that this public health framework can be a really convenient way to sort of break up the different causes, the different factors that affect whether we get sick. So when we're talking about a viral agent, we're talking about these very small infectious disease agents that can replicate only within living cells. They don't survive for long. They don't divide and replicate outside of that setting. And these agents are peculiar in terms of just how small they are. So this is a bit of a depiction of, you can see the flu virus here, and you can see a frog egg here with orders of magnitude in terms of the size of these different types of entities. What we can say is that the coronavirus, when compared to the human, it's a millionth the size of the human. That is, in that single dimension. If I'm 5'6", then the coronavirus is a millionth of that size. At the very least, viruses contain genetic material, either RNA or DNA, and a protective protein coat. In many cases, there can be additional features or anatomy of the virus. So for instance, in the coronavirus up here, you see these spike proteins, which I think we've come to know and fear to some extent, because these spike proteins are really what determines the infectiousness and to some extent the virulence of different coronavirus strains. Viruses are not really considered living organisms because they don't have this self-sufficiency to divide and replicate all on their own. They're essentially hijacking the cellular mechanisms within the cells that they infect. And these are hugely common and a very diverse set of agents, many of them not at all harmful. And the ability to mutate rapidly is one feature of viruses that sets them apart from other organisms, which may be able to mutate and change over time, but do so relatively slowly compared to viruses. In terms of the viral agents that cause human respiratory infections, I'm going to focus on some of the main categories. And for some of you, I'm sure this will be review and perhaps something that you could find on Google. But I'm going to try to make some connections between some of these topics that I'm talking about that I hope will take you beyond kind of the typical Google search. So one thing about viruses is that they tend to be specific in several ways. One way is they tend to be specific for the season. Here we see the number of influenza cases from 2015 to 2022. And you can see that while there's variation here, most of the big peaks are right around January in the middle of winter. They are also quite often specific for the host and for certain host cells. This is called tropism. So particular viruses often can only infect one type of organism. Or for instance, in the case of influenza, they may be limited to several different species, including pigs, wildfowl, and humans. And in many of these cases, the viruses can only affect a certain subset of the cells of a particular organism. So with the viruses I'm talking about today, they all are set up so that they can only affect and only infect cells that are in our respiratory tract. And I'll get back to a little more on that in a moment. One thing that's very interesting, and I think is one of the bottom lines of my talk, we have all these different viruses out there, all these substrains within these viruses. But the fact is that there are some really common elements and common symptoms that all of these viruses produce. As I said, there are seasonal patterns of infection. They can vary between these different viruses. Some of the main viruses that I'll be talking about today are influenza, typical coronaviruses, atypical coronaviruses like COVID-19, the rhinovirus, parainfluenza, adenovirus, and then something that you've probably heard quite a bit about is the respiratory syncytial virus, or RSV. And then, not to be left out, I want to make sure that we think a little bit about measles as another human respiratory virus that fortunately we kind of take for granted that we don't have to deal with it. But if you've been following the news, you will have seen several outbreaks of measles taking place around the country. So I think when we talk about this large category of infectious agents, we really do need to include measles in that list. So in terms of transmission, what occurs with viral infection is that there's the infection of a cell, the virus takes over some of the machinery of the cell, and in that way replicates, basically producing a large number of viral particles based on the use of the cellular machinery. Those cells then burst open, and essentially there's the process of shedding. So virus sheds from these infected cells and from areas where many cells are infected. In general, these are quite infectious and contagious viruses. So close contact, respiratory droplets, in many cases contaminated surfaces, are all capable of transferring the virus from one individual to another. The main way that this is done is through droplets. And essentially, these are small drops of saliva and mucus that are expelled from our mouth that contain viral particles. Some drops may be very small and contain only a few viral particles. Other drops may be larger and contain a multitude of viruses. These small drops, while it's kind of obvious that they occur from coughing or sneezing, also can be generated just by regular conversation. And it's interesting that different languages apparently have a different predilection for producing droplets on the basis of simply speaking. This is an illustration that kind of gets across this idea that these droplets are generated in our respiratory tract and can vary from being very large to being very small. The largest of these particles tend to travel relatively short distances and tend to land or come out of the airstream relatively quickly. So you can see here that these large droplets are in the air for 5 seconds, and maybe they travel a meter. As we go down in size, the particles go farther and stay in the air for longer, all the way to this extreme example where a viral containing droplet may actually end up 45 meters away. In other words, about 160 feet. And that droplet can stay in the air for about half a day. So this is a very clever way, I would say, of viruses finding their way from one organism to another. And of course, we have ways that we might be able to prevent some of this transmission. But it's important to understand that this process of droplet transmission can occur prior to any symptoms showing up. An individual can be infected with a virus. These viruses can be infecting individual cells and replicating and then shedding even before we are aware that we are infected. And this illustrates this idea that for these respiratory viruses, they can actually survive a relatively long time outside of living cells. They can't replicate, they can't divide and create more of themselves, but they can just survive as long as they are eventually picked up by another host. So one of the things that I feel has been neglected to some degree is the idea that we should be very concerned about our susceptibility to infection. Now, in some ways, it would be convenient if everyone had the same susceptibility. But the fact is that the youngest members of society and the oldest tend to be the most susceptible. Pregnancy as well makes women more susceptible. It's also true that susceptibility is determined by our past exposure. And the idea being that past exposure to a particular virus or a strain of virus can lead to the development of immunity. And of course, this can occur with infection or with a vaccine. Environmental factors can be really important as well, including air pollution and secondhand smoke in the home. If we kind of depict this as a continuum from those who are healthy, living a healthy lifestyle, they're at the lowest risk of infection and the lowest risk for severe symptoms from a respiratory infection. Then there are people in the middle, and then there are those people with underlying health conditions. So if we just review these, the healthy lifestyle are going to be people who are sort of doing all the right things in terms of health behavior. And of course, if you know the statistics of these sort of behaviors in the country, this is a very small minority of the population. More likely is a population that's at average risk with issues with overweight or obese, being sedentary, having depression or anxiety, smoking and alcohol use. So this places people at considerable risk beyond that optimal state. On the other hand, even at greater risk are those people with chronic diseases, including diabetes, lung disease, and heart disease. Some of this has to do with the compromise of the immune system with these conditions. But in the case of lung disease, it also speaks to the fact that lung tissue that is damaged and diseased is more vulnerable to infection. So what are the symptoms of respiratory viral infections? I think much of this is well known to you. I like to split this up into three categories: upper respiratory, lower respiratory, and systemic features or symptoms. So when we're looking at the respiratory tract, we really have our mouth and nasal cavity, our throat, down to our larynx and our vocal cords. This constitutes the upper respiratory tract. And we get symptoms such as runny nose or congested sinuses, irritation in the sinuses, sore throat, headache, hoarseness, and sneezing as a result of viral respiratory infections. And in some ways, these are the more kind of inconvenience type symptoms. Of greater importance are the lower respiratory tract. These have to do with the lungs, and ultimately the lung goes from the main tube, the windpipe, the trachea, into these much smaller and smaller bronchioles, and then into these air sacs or alveoli. It's in these areas where some of the serious symptoms occur, including productive cough with sputum, a non-productive dry cough, shortness of breath, wheezing, and chest pressure. But there is a third category, and that being kind of the systemic or whole body symptoms of these infections. And these are things like fevers, chills, fatigue, malaise, muscle aches or myalgias, and reduced appetite. And I think, every single one of us has had different viral infections, those infections may vary in terms of which of these are most prominent, and different viruses will cause more severe symptoms than others. So in terms of the biology of viral symptoms, it's very important to remember that there are really two causes. One is the viral invasion of our cells itself, and then secondly is our inflammatory reaction. Now, that the severity of an infection is really determined by both of these. And of course, viruses can invade these specific cells, leading to tissue injury. And this is certainly the case with sore throat, with bronchi in the lungs, and with the air sacs or alveoli. In this case, the virus itself is causing injury and doesn't necessarily depend on our immune system getting involved to cause problems, to cause severe symptoms. On the other hand, it really is often the inflammatory reaction that explains most of the symptoms, at least those that are occurring after the virus has taken hold and the body has started to fight it off. Now, an inflammatory reaction is absolutely necessary. This is how our body clears itself of viruses, bacteria, and other infective agents. If we didn't have this inflammatory reaction, we wouldn't survive very long. On the other hand, there's a certain way in which the inflammatory reaction to these viral respiratory infections is a biological overreaction. And this manifests itself by local symptoms like lungs, sinuses, and throat, often with lots of white blood cells targeted to those areas, lots of action going on where the immune system is trying to kill off the cells infected with the virus, but in so doing has neighborhood effects that also make us feel less than great, let's say. Also, the systemic symptoms are often due to the biological overreaction. These are the fevers, the muscle aches, and in the case of COVID-19, this particular phenomenon called cytokine storm, which is essentially the immune system ramping up and suddenly putting into the bloodstream all of these chemical signals that tell the immune system to ramp up even further, to sort of amplify the inflammatory reaction that's already going on. So the time course of respiratory infections, I think, is a very important thing to understand. First of all, there's an incubation period. This is essentially the delay between being exposed to the virus and the development of symptoms. And I will review some specific information about specific viruses in a moment. The contagious period is that time when we are actively shedding virus. That is, the time during which we are putting out virus that can then go on to infect other people. The acute symptoms, as I said, are viral tissue injury plus inflammation. That occurs in some cases only for a very short time, a day, several days to a week. The late symptoms are usually all inflammation. And one way that I like to describe this is that what we have is the infection that takes a while to take hold. It takes hold and starts to give us symptoms. Our body is very vigorously reacting to that infection. Our body is actually pretty good at clearing out the virus and slowing it down and eventually clearing it from our body. But that inflammatory reaction has a life of its own. It goes on even after virus has been cleared. So I drew a little picture here of kind of this time course where we have exposure, and then we have incubation and acute symptoms. And we have viral shedding. And notice that viral shedding occurs before the acute symptoms and can occur after the acute symptoms. We also have these late symptoms, and I'm going to talk specifically about this issue of very late symptoms, including chronic cough. I also want to point out that it's in this later period of time where the body is often more vulnerable to other infections. In some cases, these are bacterial infections like pneumonia. In other cases, it's infection with yet another respiratory virus. In terms of evaluating the symptoms of respiratory infections, I just want to kind of get across that there are these very relatively common symptoms, and we've all experienced them. But the same viruses are capable of more rare, severe symptoms, which lead to respiratory failure. And of course, this is the pathway that was that caused the death of so many people from COVID-19. And this issue of how severe the symptoms are, again, depends on many factors, including some that are virus specific, some that have to do with the underlying health issues of an individual, and whether that person has had past exposure to either the virus itself or a vaccine for the virus. Except for those rare cases where severe symptoms occur, I'm going to make the claim that most respiratory infections can be self-managed, including self-testing for COVID-19. And in a healthcare setting where we don't necessarily want people who are infectious coming into healthcare settings, I think this type of model is going to become the norm. A bright light on the horizon is that very likely we'll have more home test kits for other viral infections, including influenza, parainfluenza, and RSV. So this whole issue of how to treat a respiratory infection, I think we're moving in the direction of having the patient and the patient's family be the real managers of this. At the same time, high-risk individuals or those with severe symptoms should seek medical advice. And that advice, in many cases, can be telephone or video visit. At Stanford, one of the models we've used is to really restrict those with viral respiratory infection symptoms to the urgent care clinic rather than having them come into the primary care clinic. But in my mind, I think we should all become much more comfortable being evaluated via video visit. And of course, to the extent that symptoms become more severe, these also really mandate seeking medical advice and testing. And some of the red flag symptoms, those things that really should not be allowed to last for too long without checking in with a healthcare provider, are fever, particularly above 101.5 or 102, shortness of breath that's brought on by simple walking, a cough with abundant sputum that is either brown or bloody, indicative of a potential pneumonia infection, and then chest pain is the other thing that we need to be careful about. So what I'm saying here is that we have this whole range of possible symptoms from different viruses. Many of these symptoms are quite manageable. There are severe symptoms, but depending on the virus, these are not going to be particularly common. We need a system of management which seeks out those people having problems, but also keeps people who are having more common symptoms at home away from others who they could infect. So in terms of some of the virus-specific symptoms, I've been talking about this whole group of viruses as one large group. And, I think there are some reasons to do that. But there are some interesting and important differences between these viruses. So obviously the virus on everyone's mind should be COVID-19. This virus has high transmission. It has potential for severe symptoms. It rapidly mutates, and it has a long viral shedding period. COVID-19 is here to stay to some degree. And I don't expect that it's going to go away entirely anytime soon. But I think there is the potential for some of these other viruses to kind of be the new source of pandemic. So influenza obviously is at the top of the list. Influenza has a very short incubation period. It does cause severe disease, particularly in the most elderly. And it has this peculiar potential for secondary infections. Most people who die of influenza don't die of the viral infection itself, but they die of a secondary infection, often with a bacteria causing bacterial pneumonia. RSV is a very interesting virus, mostly affecting young people, seasonal in the fall to the winter, a little bit earlier than influenza, has a very broad range of symptoms, but it's also out there as a potential, a potential virus to cause outbreaks. Parainfluenza, adenovirus, rhinovirus, and typical coronavirus, these are your more lightweight respiratory viruses. And really, they often are presenting as common cold with milder symptoms and usually less transmissible, although that depends on the particular virus. There are a multitude of these viruses out there, different substrains within each of these. And one question I often get is, well, couldn't we develop a vaccine for these? Potentially, but there's so much variability and so many different viruses out there. We really need to produce a vaccine with hundreds of different components, and that those different components would probably vary year to year. And then not to stop there, I do want to mention measles again, with its long incubation, its presence of rash, and its very high transmission rate. And here are some little, kind of depictions of these different viruses. Some of them very small, like the rhinovirus, some of them very large, like RSV. Many of these are RNA viruses. Influenza and adenovirus are DNA viruses. So I wanted to just talk over kind of an interesting concept, which is the idea of basic reproductive number. This is a measure of the transmissibility of a particular viral infection, and essentially represents the average number of susceptible individuals that can be infected by one infected individual. So we have a whole range of different R0 values, and different viruses have different degrees of transmissibility. You can see here that measles and the chickenpox virus, herpes zoster virus, are quite transmissible. COVID, RSV, influenza, not quite so much, but not lightweight when it comes to transmission of these viruses. And then less transmissible is, for instance, the adenoviruses. Also have on here hepatitis B, which isn't a particularly transmissible virus, except that it uses routes of sexual transmission maternal to infant transmission and IV drug use, but is not particularly a strong virus in terms of being infectious. And then hantavirus, a very unusual respiratory virus infection, is actually very difficult to transmit. The problem, of course, is that about 40% of people who acquire the virus will die from the virus. So one piece of advice I'd like to offer you is to be ready to answer some particular questions when you call in or when you're on that video visit with your healthcare provider. So let's say you're calling me on the phone, and I'm going to ask you some questions. These are the questions you should be ready to answer. So what is your most bothersome symptom? What do you think your most serious symptom at this point is? What's the full range of other things that have been going on for you? So again, we really want to kind of try to let the doctor know what symptoms we have and what problems we're having. Do you have any shortness of breath? And if so, with what kind of activity? Just walking or walking up 3 flights of stairs, going to the bathroom? Do you have any productive cough? And tell me about the color and amount. Also, do you have any sore throat, or are you having any GI symptoms along with all these other things? You know, what's your maximal temperature? And I really want to know the temperature that you've measured with a thermometer, not just that sense of, well, I must have been quite feverish because I felt crappy. So having a thermometer in the home is an important investment. What have you taken for your symptoms, and were the symptoms helped by this? And then have you had any contact with individuals who were sick? And do your symptoms seem to match up with what theirs were? And then most importantly, kind of, is anyone else at home that's sick? And is there someone in the home to look after you, to kind of be your caretaker if possible? That's not always the case, not always necessary, but I'd like to reassure myself that there is someone in the home or someone who can come to the home if necessary. So I wanted to just touch on some of the other clinical conditions that we need to kind of keep in the back of our minds when we're thinking about viral respiratory infections. There are some conditions with overlapping signs and symptoms, and these are particularly bacterial respiratory infections. And these can include things like pneumonia, bacterial bronchitis, sinusitis, middle ear infection or otitis media, or strep throat. All of these overlap with the sort of symptoms that come with viral respiratory infections, but tend to be a little different, particularly the production of more mucus and more ugly looking mucus that's brown or dark yellow or green with these sorts of infections. Viral gastroenteritis or a GI infection are relatively unusual with respiratory viruses, but they can occur. It's also important to recognize that a lot of other causes can be involved with GI symptoms, including things like food poisoning or exposure to something in food. And this is one of the things that needs to be considered. Also, respiratory allergies. And of course, this is a dominant type of symptom that people are having right now. Usually it tends to be spring, with some of these viruses being more prominent in the winter or fall. But nonetheless, there is an overlap between some of the symptoms. I want to touch for a little bit on treatment of respiratory infections. Supportive care is really the foundation of treatment. This is getting the hydration, the rest, and the good diet that helps us feel better. It also means using anti-fever or pain medications. I generally recommend acetaminophen before using naproxen or ibuprofen, which are in this NSAID class of medications. Also, there is a role for symptom-specific therapies like cough suppressants or decongestants. One of the most important things, of course, is to avoid transmission of a virus to other individuals. For some viruses, there are specific medications that can help. These are usually limited to use for more severe symptoms or for people who are at risk of having very severe symptoms. And this is the susceptibility of a particular virus can change. And so these are not necessarily going to be the same medications that, let's say, we're using 4 years from now for these 3 different viruses. And then I think that it's important to mention that there are some medications that are really for severe disease, almost regardless of which virus is causing the disease. And these include a steroid, particularly dexamethasone, and some drugs that modulate the immune system, essentially calm it down. One point I want to make is in general, antibiotics are ineffective, and they have the very serious implication or consequence that they can lead to community bacterial resistance. That is, growing bacteria in our midst that are resistant to antibiotics. I did want to mention the long cough syndrome. You know, of my exposure to people with viral infections in my clinic, I have to say this is actually where most of the action is. For those people who have a very serious infection and are asked to come in, they generally come into the urgent care clinic. But I do see people after they've mostly gotten better from their viral infection, but have these lingering coughs. And this is a very common set of symptoms after the viral infection. You know, for the most part, these are either non or minimally productive. That is, there's not a whole lot of sputum production that goes on. It's usually a mostly dry cough. It's usually a very annoying cough that can certainly interfere with sleep or with activities. My general advice is that we need to wait about 6 weeks following acute illness to evaluate this long cough. Yes, it is possible that this cough from a viral symptom, from a viral syndrome, could evolve into a secondary infection. Usually it's more than just the cough, however. And I do want to point out that this is a very long wait. And, you know, I often have people showing up in the office a month after their acute illness saying, I expected this cough to be done by now. The fact is that, you know, often 6 to 8 weeks is a more realistic endpoint. Not that everybody goes that long, but I want to reassure you, in most part, those cough symptoms that continue for a long time still don't indicate any sort of other problem. But they are a very important impediment to getting back to normal in terms of functioning and sleeping and resuming things like physical activity. And in general, having this long cough does not mean you have a secondary bacterial infection. So again, antibiotics for this long cough syndrome are generally not very useful. But there are a few useful therapies out there. One is to use an asthma inhaler, particularly albuterol, to reduce bronchial irritation. To some extent, the cough is being triggered because the lining of the tubes in the lung is still irritated and inflamed. A remnant of that initial inflammatory response that our body had to the viral infection. And then in many cases, a stronger cough suppressant may be needed to kind of allow you to get by and be productive, even in the state of having this long cough. So I've changed my practice over the last couple years, even though there's such great reluctance to prescribe opioids. I think for some people with this syndrome, a short course of a codeine-containing cough syrup may be quite warranted. Can't talk about these viral infections without talking about vaccination. And I'm going to go through these a little more quickly because I can see that I'm running out of time here. But, this is the benefits of vaccines is that this provides a pre-exposure that can either prevent transmission or greatly reduce severe disease. And we've really demonstrated the value of vaccination with COVID. There are some harms, though, and one of them is that it's very common to have a flu-like symptoms for a day or two even following vaccination. And then there are some uncommon or perhaps unknown harms that we're still investigating. But I would say overall, the vaccines we have for respiratory viral infections are quite good and in general have benefits more than harm. In general, we recommend some vaccines for subpopulations based on their risk. And the idea is that higher risk individuals have greater benefits versus harms compared to somebody who's at average risk. If I'm a high risk individual, then getting vaccinated will probably give me greater benefits than the average person. I might have a little more harm, but probably not that much more than the average person. There does seem to be a need for frequent boosting of the immune response. We have vaccines for influenza A and B. These are actually recommended to the entire population over the age of 6 months. We, of course, have COVID-19. This needs to be periodically reformulated. And my guess is that this is going to become an annual vaccine, much the way we have with influenza. Respiratory syncytial virus also has a newly available vaccine. The focus here is really on infants and adults over the age of 60, as well as those with immune compromise. And then I have to say, measles, we really need to focus on universal vaccination with the MMR, or measles, mumps, rubella vaccine in children. We run a great risk if we have a large number or pockets of children that are susceptible to this disease. So prevention strategies, this should be of no surprise that things like hand hygiene, respiratory etiquette, avoiding close contact are very important, as is vaccination. We also need, in some cases, to be concerned about cleaning surfaces, particularly counters and doorknobs. It's also important to focus on ventilation. Outdoors is better than good ventilation. Good ventilation is much better than poor ventilation. And then masking and avoidance of public gathering during pandemics or peak seasons, I think is going to become more of a pattern that we see in future years. And one of the reasons for this is I think we really do need to be in pandemic preparedness mode. We were caught off guard in many ways by COVID-19. And in some ways, we need to prepare for the next pandemic seriously, knowing that there will be major adjustments necessary, but we need to be more ready than we were for COVID-19. One of the areas that I focus on is this idea of reducing your susceptibility through healthy lifestyle behaviors. And essentially, we've been told that these sort of things like physical activity, diet, weight, sleep, stress, social networks, and substances are important for reducing our risk of chronic disease. They also are important for reducing our risk of viral infections. And they also are important for reducing our risk of more severe symptoms should we be infected with one of those viruses. I think we need to obtain the recommended viral vaccinations. We need to really make it a habit of good hand washing and covering coughs, even if we're outside of flu season. We need to avoid sick contacts, stay home from work, and also be comfortable with the idea of remote care as a way of evaluating a viral respiratory infection. And of course, masking if recommended. So these are kind of the personal strategies that are out there, but I'd also like to flip this and sort of say that from a societal perspective, we also need to do better in terms of preparedness. This includes, reducing the susceptibility of the general population. This wasn't something that I heard a whole lot about during COVID, but the fact is that far fewer people would have died had we had a healthier general population, a population that was more physically active, eating healthy diets, getting enough sleep, was not overweight or obese. So these things are important in terms of at a societal level, trying to minimize the societal toll of a pandemic. Obviously, we should be promoting healthy lifestyles because this is yet another reason to put our attention on these health behaviors and not just rely on medications. We need to be ready with rapid vaccine development and distribution in the hopes that we can reach a herd immunity through vaccination quickly enough to prevent the sort of harms that occurred with COVID-19. We also need to focus on discovering new drugs, especially for those people who are susceptible to severe disease, including those who are susceptible because of their own chronic disease issues. We need to encourage hand washing and covering coughs as the norm, masking, of course, and we need to think about the economic adaptability. We need to be more adaptive and flexible in terms of our workforce and not having another pandemic shut down the economy as severely as COVID-19 did. We also need to focus on healthcare capacity. Can we remotely evaluate infections? Can we remotely vaccinate people? Do we have enough trained healthcare workers? Do we have enough intensive care beds? And of course, another feature, a public health feature, is this idea of contact tracing and surveillance, as well as early warning systems. One thing that has been put in place, I'm happy to say, is this idea of wastewater testing. We can test wastewater to get an idea in aggregate about how a community is doing in terms of various viruses. So I'm going to end with just my major messages. There are similar strategies for preventing, treating these different viruses. These viruses have obvious differences between them, but a lot of the foundation is identical. We need to have prevention strategies to reduce exposure and focus on susceptibility prior to exposure. We need to really live up to this idea of reducing our risk. These are the strategies that we all know and care about. We need to be comfortable with self-management for supportive care and be knowledgeable about what these red flags are and how they should prompt us to seek additional advice from healthcare providers. Obviously, we need to vaccinate when recommended. And, the fact is, the next pandemic is going to occur. So it's not really if, but when and with which virus are we going to be coping with? So I'd be very happy to take questions, and thank you so much for your attention.
Okay, looks like there are a few questions in the chat. I'll read them out. Question 1, if someone received 2 MMR vaccines in childhood and have a negative titer in adulthood, would you recommend for them to get a booster MMR dose?
Yes, I would. In essence, they still may have some lingering immunity, but the negative test as an adult suggests that immunity has waned over time. So, there might be some exceptions of those people who have absolutely no contact with children or with women who are pregnant. But I think those types of exposures are common enough that, we really should be vaccinated against measles, mumps, and rubella.
Thank you. Are there strategies to deter a cold from triggering a sinus infection?
I think there may be some strategies out there. I'm not sure how well proven they are, but I will say that taking care of oneself, getting the rest, the hydration, the intake of some food is very important in terms of our body's resources and ability to limit the symptoms or limit the extent of an infection. And yes, a secondary infection with a bacteria causing sinusitis does happen after these viral infections. And I think while there may be some specific types of strategies, I think the general strategy of taking care of yourself is really the best advice.
And last one, are there strategies to deter a cold or allergies post-nasal drip from triggering a respiratory long cough issue?
Well, in general, that post-nasal drip is one of the causes of the long cough syndrome. And in those cases, it may be important to identify what is the precipitant, what is causing the postnasal discharge from the sinuses. If it is a particular compound or something in the environment, we should try our best to get rid of that exposure. Not always possible with things like cats or dogs, and therefore using strategies to reduce the symptoms or the amount of dripping with a allergic rhinitis may be important. Things like, for instance, using a nasal steroid.
That's it for the questions. There are lots of praise for the slides and lots of thank yous in the chat. And we just want to say thank you, Dr. Stafford, for sharing this great information. Thanks to our audience for joining us and for the great questions. If you'd like additional information or resources, please contact Stanford Health Library, and we hope you'll join us for our next lecture.
Thank you so much, Elisa.